So I've been asked to talk about health and wealth and the case for investment. And if I get this right, go the right direction. In a strange way, this is sort of trying to catch up with where we were about 5 or 6 years ago before the economic crisis. Because back in 2008, the European governments came together in Tallinn in Estonia and with the World Health Organization. I was part of the process. And we looked at the arguments for investing in health there. And the government signed up to a commitment that, beyond its intrinsic value, improved health contributes to social well-being through its impact on economic development, competitiveness, and productivity. High-performing health systems contribute to economic development and health. That was accepted. And then, shortly afterwards, we had the European Union Health Strategy. Fundamental principles for European Commission action on health were based on the idea that health is the greatest wealth. And that, in fact, was based to a large extent on work that we had previously done for them, some of which I'll pick up here. And then, of course, in France, the president asked Joe Stiglitz, the Nobel laureate, to look at the role of the contributions to wealth and the wider measures of progress in societies. And he talked about how the time is ripe for our measurement system to shift its emphasis from measuring economic production to measuring people's well-being. So this link between health and wealth was it really had a momentum at that time. And then, of course, the financial crisis hit, and sadly, it all rather got forgotten about. So what is the evidence behind the health and wealth story? What I'm going to say today is to suggest that a lot of it depends on precisely what we mean by the economic consequences and costs and how we measure them. There are different ways of measuring the progress of nations in terms of wealth and in terms of health. And I'll conclude that there is a strong economic case for investment in health, but it's rather nuanced. And if we're going to be able to present this argument, and tomorrow I'm giving a talk at the New Zealand Treasury, if we're going to be able to present this argument, we have to do it in a way that is coherent and reaches out to the appropriate audiences. Now, this is something I actually have talked about before in New Zealand, and it's work that we did in the lead up to the Tallinn conference, where we were arguing for the positive interrelationship between three elements: health, wealth, and health systems. And essentially we argued that the ideal was to move into a virtuous cycle where better health led to better health systems, reduced demand on health systems, better health led to economic growth, more economic growth meant that there was more money for healthcare, and so on. Or alternatively, and what we could not have predicted at the time with austerity after the financial crisis, that disinvestment in health and disinvestment in health systems could lead to a vicious downward spiral. And so in the book that accompanies this, that Josep Figueres and myself edited from the European Observatory, we pulled together all of the evidence on these sets of relationships. And of course, there are some easy parts to those relationships. Wealthy people in wealthy countries can make healthier choices. Greater wealth provides more money to spend on health systems if you choose to do that, or on other things that you might want to do. And some of these relations are well known. The wealthier the country, the better the health up to a certain level. After that, it tails off a bit, but certainly there is a relationship there. But the questions that I want to really deal with today are really, does better health increase wealth and or reduce future healthcare costs? Now, if we're going to answer this question, we need to understand what we mean by the different costs and benefits that we might be thinking of. One is, of course, the cost of providing healthcare. The very narrowly defined cost. How much does it cost to provide a course of treatment or an attendance at a hospital or a couple of days in a hospital bed or something like that? That's one element of cost that we're interested in. Of course, those of you who are health service managers will be particularly interested in that. But I would argue that when we're talking to the Treasury, there's a different set of arguments that we want to look at, and that is the productivity costs and benefits, the extent to which better health allows people to be more productive, to contribute more to economic growth, both at a micro level and a macro level. Essentially, do healthier people contribute more to the labour force? Do they do more? Do they achieve more? And do they stay in the labour force for longer? But there's more to it even than that. That's what the Treasury are interested in. All of you as individuals, you place a value on health. If you were asked, would you be willing to, we always say, you cannot put a value on a life. Well, of course, economists do. But the key here is that we all do place a value on having good health and on living a year longer. People are prepared, and we know that, are prepared to pay for longer and better lives and better health. So what do we understand about that? And then I want to discuss very briefly the case for state intervention. Which are the costs that the state should be involved in, and which are the costs and benefits that it might not be interested in. So let's begin with the healthcare costs. Let's start narrow, and then we'll move out much wider. Does healthcare reduce improved health reduce healthcare costs? Or put another way, does ill health increase healthcare costs? Well, it's sort of obvious, really, isn't it? If everybody was perfectly healthy, then we wouldn't actually need a health system. The ideal is to get to that situation where everybody lives to be 100 and then suddenly drops dead. Which to a large extent is what happens in Japan, actually. If you look there, there's a very low level of comorbidity. A famous paper asked about the very inefficient Japanese health system and yet the very low cost. They said, is it the healthcare system or is it the fish? And they concluded that it was probably the fish because of the very healthy diet, although Japan Tobacco International are doing their very best to reverse that. But essentially, that would be the ideal. But of course, we also know that healthcare does cost money. And this is just an estimate, the cost per capita of cardiovascular disease, the direct cost of treating cardiovascular disease in a number of European countries. So 400, this is old data, so the figures would be higher now. But in euros, we're talking about up to 400 euros in some countries, particularly Germany, which has a relatively expensive healthcare system, the UK, which has a relatively high level of cardiovascular disease, and all the way down, so we get down to the bottom where Spain and Portugal obviously have much lower rates of cardiovascular disease, and they have relatively cheap health systems. But the key point is that it does cost money to pay for people with illness. So you think, would it be better if we can reduce that burden of illness? And we can look at it in other ways. We can look at the additional per capita cost of someone who is living with obesity or smoking or problem drinking. And the direct costs that fall on the health service are significantly increased by people who have any of those particular characteristics. And again, that's not altogether surprising. If you do these things, or if you have these characteristics, you can expect to incur higher costs because you will go to your doctors, you will get treatment, you will take tablets, you will need operations, and so on. But here's the real challenge. The other characteristic of many people who have very unhealthy lifestyles and who have high levels of risk factors is, of course, that they die early. Now, this is an argument that has been exploited by the tobacco industry, most notoriously in its case to the finance ministry in the Czech Republic, where it argued against any restrictions on tobacco because this was an ideal way to save the pension bill for the Czech Republic. Now, of course, the Czech government have had experience in the past of people coming from other countries seeking to reduce their lifespan, and they weren't terribly impressed by that. They had memories that went back. But that was an argument that was made, that wouldn't it be great, people with who smoke all their life are likely to die in their mid-60s just about at the time they're going to draw their pension. So there was a strong economic argument for getting as many people to smoke as possible. But those with unhealthy lives may cost more while they're alive, but of course they do not incur any cost for the health system once they have conveniently or inconveniently died. So we need to take that into account. And it's a rather complicated equation when we look at it, because we know that the additional, if you have less disease and disability at a given point in time for a given population at a given age, you will spend less. The population who are living are healthier. But if they live for longer, even if they only use a little bit of health care, and by the time you get to your 60s or 70s, you're likely to have some conditions, be they hypertension or arthritis or something else. So you're going to spend some money. There's going to be an additional cost associated with those extra years. Cheaper if you're dead, but there you will cost a bit of money. We also know that really the costs that are associated with an aging population are not so much in terms of acute care the cost of being older, because older people are healthier generally as we have aging populations. It's the cost of dying. The cost of dying is really expensive, and to some extent it doesn't matter what age you are when you die, except When you do get to be very old, and when you get to 85 and above, there you see that the cost of dying actually is quite a lot less, because people have implicitly or explicitly adopted this idea of a fair innings. They're less willing to intervene, unless, of course, you're in the United States, where you have Medicare and you have special provisions for dialysis and so on, and where if you are in an American hospital, you view somebody who is at an elderly age on a ventilator and on a dialysis machine as essentially like an ATM, where you don't need the PIN number. But in most healthcare systems that work on sort of rational principles, then people do tend to intervene less at older ages, and so it's actually cheaper to die when you're older. But on the other hand, with increasing infirmity, there may be higher social costs that we need to take into account. Again, we need to be a bit cautious. Carol Brain's work recently from Cambridge in The Lancet shows that the age-specific prevalence of dementia has actually fallen rapidly, about halved over the last 30 years in the United Kingdom, because as people are living longer, they are living healthier. So we need to be a bit careful about that. But certainly there will be some additional costs of social care. So what do we get when we try and pull all of this together? Well, certainly in the short term, as long as people continue to live, we can see a very significant return on investment. So if you take about $10 and invest that in proven community-based disease prevention programs, physical activity, nutrition, reducing tobacco use, you can significantly reduce the rate of diabetes and heart disease and kidney disease and stroke, some cancers, and so on. And essentially, the return on investment while those people are still living is about $6.2 for a return of investment, about $6.2 for every dollar invested. So that's a significant return on investment. Keeping people healthy will reduce future healthcare costs. But then we have the question of those people living longer. So what do we get when we see that? And this is a Dutch study that has followed up panel data. And we see that if somebody is a 20-year-old, they can, if they live in a healthy lifestyle, they're not obese and they don't smoke, they can expect another 64 years of life, live to about 84. If they're significantly overweight or if they smoke, then their life expectancy is reduced. The total amount of healthcare costs that on average they will spend over their lifetime for the healthy people will be higher because they live longer, but they will have those additional years of benefit. And the question is, how much more are we likely to have to pay for those additional years? And actually, I think 7,000 euros for a year of life, many people might think in a rich country is not an awful lot. But of course, that's a judgment that you have to make. So here we see that you are actually getting significantly more years of life, but it is costing a little bit more. But you're getting the benefit of the value of that life. Fortunately, if we were to simply take that and say, well, we're not prepared to spend that, then we would go to the Philip Morris approach to the Czech pension problem. And we would say, well, actually, we would like everybody to die as soon as they get to pension age, because then you would save even that 6,000 to 8,000 euros per year. But that isn't really a sensible criterion for the way in which we might want to proceed. So instead, what we might want to look at is whether if we invest in people's health, we get more economic value out of them. And these are people that are in the workforce, clearly. But of course, as we now know, the workforce extends well beyond the standard retirement age in many countries. People continue to contribute either in a paid or an unpaid role. For example, grandparents providing childcare and so on. So we need to be quite flexible in what we look at in the workforce. And I'm going to look at the microeconomic and the macroeconomic elements. And this is really more relevant. If you're a finance minister, this is the sort of thing that you really should be interested in. The former bit was, if you're running a healthcare system, what are the direct costs? But if you're looking at the whole of the economy, as you would expect a finance minister to do, this is what you'll be interested in. We've written quite a bit about this. The blue and white report on your left was the one that we originally did for the European Commission, which really made the case for the health and wealth strategy. And the others have been looking at the situation in the countries of Central and Eastern Europe, where most of my primary research is conducted. And then the earlier book looked at Europe as a whole. And there are a number of ways in which health might contribute to the economy. So it may well be that healthier people are more productive. It may well be that they stay in the workforce for longer. It may well be that if they're healthier, they're more likely to invest in their own education and therefore become more productive because they realize that they will be around to see the benefits of that investment. And it may well be that they will save more for pensions, and by putting more into their pension funds, there will be more capital in the economy that can be invested. Or they may put more money into their small and medium enterprises. They may save in ways that contribute to economic growth that way. These are possible mechanisms. The question is, what does the evidence show? Clearly, there's also a positive feedback loop there, because if the economy is thriving, providing the money is being spent in appropriate ways, then that can feed back into allowing people to make healthier choices. They may not make those healthier choices, but at least they have the opportunity to do so. So what do we know about the evidence on health and productivity? Well, we have a lot of evidence from low-income countries. This is the very famous report, the Commission on Macroeconomics and Health, chaired by Jeff Sachs at Columbia. And that showed definitively that better health improves economic growth in poor countries, eliminating malaria, removing sleeping sickness so that you can get cattle into places that they couldn't previously graze. So it's just animal and human health, but human health in particular, allowing more children to survive and so on and so forth. That was the starting point when we began to do this work about 2005. And at that stage, nobody had really pulled the evidence together. Obviously, there was evidence, but it hadn't been pulled together. And our challenge was that things are different in high and middle-income countries. Because you can see how, if you're living in an agricultural society in East Africa, it is important to be healthy, because the things that you do are going out into the fields and harvesting crops, or working in mines or extractive industries. It's hard physical labor. Physical labor of that sort is much less important in countries like ours. We have all sorts of labor-saving devices. All of you have in your kitchens the equivalent of a small factory in Victorian times, simply in terms of the washing machine and the cooker and all the other things, or the fact that you've got running water and so on and so forth. So what do we see when we look at the evidence? Well, actually we see, and I just take here, and these are just a selection of examples from the books that we have published and from the other studies that we have published. But we see, for example, from the United States, an old study, people in poor health earned significantly less, about 6% less than people who are in good health. There's a racial issue here, which is not surprising, of course. If you look at what's happening in Ferguson, Missouri, there's actually a racial issue to nearly everything in politics in the United States. But what we see is that black males are more likely to drop out of the labor force or cut their hours. White males are more likely to cut their hourly rates. But the key point is, less healthy people earn less per hour, and that is a measure of their perceived productivity at work. Another study, people at age around 50 earn 20 or 30% less if they've had certain diseases in the past 10 years. This will be a recurring theme. You'll see health shocks in middle age, heart attacks, strokes, things like that significantly impact on your productivity and your ability to stay in the workforce and your earning potential. Again, another study showing that older people earn about 20% less if they've had an illness in the past 10 years. And so we go on, not just in the United States and other countries, the United Kingdom. People in excellent versus less than excellent health have about £1 extra in their hourly wages. So they earn more just by being in that top level of self-reported health. An interesting study from Sweden, is it the sickness absences that people have that results in their lower productivity and their lower pay? Or is it the sickness itself? And in this study, they compared women who had absences from work either because they had a health problem themselves or they had a child who had a health problem. And what they found was that essentially it was the health problem of the women themselves. You did not get the reduction in wages and therefore proxy of productivity if they were missing work because of a problem of health in their child. Differences in gender, and you'll see again all the way through there are significant gendered elements to this. The impact of serious illness in men is greatest for men in their 40s, but for women in their 30s. And mental health, again the US data, but we could have found this in a number of countries. An episode of mental illness reduces wages by about a quarter, and the effect persists for at least 15 years. One episode of serious mental illness will have consequences that last for a long time. So if we're using, as one does in economics, if you use wages as a proxy for productivity because that's what the employers think people are worth in terms of their contribution, then you can see that there is robust evidence that poor health reduces productivity, reduces the contribution to the national economy. What about being in the workforce at all? What about labour supply? And remember that many countries have significant shortages, particularly of skilled labour. You have a significant shortage of doctors. You're dependent on international medical graduates. We do too. So particularly in knowledge-based economies, there is a problem if we're losing significant numbers of people from the workforce due to avoidable illness. And here again, we're seeing from Ireland, those with chronic illness or disability severely hampering their daily activities are much less likely to work. Men even more so than women. In Germany, having a health shock like a heart attack or a stroke, again, significantly reduces the probability that you will be in the workforce in the next year, but even more so after that. So people will often bounce back. They come back to work for a while, but then, having had that health shock, they don't stay in the workforce. They leave the workforce earlier as a consequence. You need to look at the longer-term effects. Again, looking at early retirement, we see from a whole range of countries, those in poor health tend to retire 1 to 3 years earlier than other people. A long-term health problem in one study, long-term health problem beginning at the age of 55, when many chronic diseases hit people, will reduce the retirement age by almost 3 years. A heart attack or a stroke after age 50 increased the probability of retirement in another study by 42%. Now, all of these, of course, are to some extent dependent on the context of the country, because we have, and we'll come back to it, an issue of how do we label those who are no longer in the workforce between the ages of, say, 55 and 64. Some will be unemployed, some will have taken pensions and early retirement, some will be on long-term disability. And essentially, the mix varies on the system of incentives in the welfare system. So as you change, you move people from one category to another. So we shouldn't get too hung up as to what label we attach to these people. The fact is that they're not actually working. And then what about the effect on carers? And this is, of course, the thing that literally the Cinderella subject of healthcare, the people who provide the informal care, the people who are often unrecognized, a significant burden falling upon people who are carers. And this is quite interesting because, again, you see the gendered element. And those of you who are women in the audience will not be in the least surprised to see this. That men who have to look after sick wives are much more likely to leave the labour force to give up their jobs. And women who look after their sick husbands are more likely to go into the workforce because they need the extra money to compensate for the loss of their husband's earnings. And they have, of course, the double burden or the triple burden and all the other burdens, and you are very familiar with that. What about education? So we've talked so far about productivity, we've talked so far about retention in the labour force. What are the implications for education? Do people who have better health invest more in their own education? Because we all live in knowledge-based economies. We need societies with highly skilled people who can contribute to the, and I hesitate to say it, but the internet-generated world in which we're living. You have a particular aspect of it here, of course, which we don't. But the new technological advances to be engaged in that global economy, whether or not you think you'll create 100,000 jobs in it or not, of course, is another issue. And so what is the evidence that we have there? Well, human capital theory will predict that more educated individuals will be more productive and obtain higher earnings. From theory, that's what you would expect. And you would expect that children with better health will have less absenteeism and low dropout rates. And there is lots of evidence from low-income countries, from Africa, from India, South Asia, Southeast Asia, Latin America. Lots of evidence that that is the case. And in fact, more nuanced aspects depending on how you extend the idea of illness. The issue now, of course, of menstruation and girls' education and the unavailability of sanitary materials and so on. So we're seeing lots of evidence of how ill health or things that lead to disability that perhaps shouldn't will have a significant impact on education in low-income countries. But what's the situation in high-income countries? Well, here again, and it's been more difficult to pull this together, but this is a synthesis that we've pulled together of the available material. What we find is that children who are in very good or better, so one of the standard questions in surveys, how would you rate your health? Very poor, poor, okay, good, or very good. So if you've got very good, good or very good health in childhood, children tend to spend about a third of a year more in school. A major illness before the age of 21 in one study reduced the period of time spent in education by about 1.5 years. Interestingly, the negative effect on educational outcomes of smoking and of poor nutrition had a greater impact than that of alcohol consumption or drugs. So physical health problems actually do have a significant impact. Obesity and overweight are negatively associated with educational attainment. Physical activity is positively associated with educational attainment. Sleeping disorders, as you might not be surprised, reduce academic and educational performance. Surprisingly little work, and we couldn't really find any, and maybe the psychiatrists here might know of some that we've missed, on anxiety and depression, given the growing concerns about mental health in adolescents in many countries, in particular the feeling for many adolescents, particularly in poorer communities, about where they're going and what the future holds and so on. Relatively little. Interestingly, asthma doesn't seem to have an impact. A study we're doing at the minute, we're looking at eczema, because that's another issue. There has been some questioning about the role of asthma on exam performances in the northern and southern hemisphere, given the seasonal variation of pollen. People have looked at that, but it doesn't seem to have much of an effect. So that's education. So what we're seeing so far is poor health does seem to have an impact on the productivity of people by what they do, how much they contribute at work, how long they stay in the labour force, whether they can be educated, educate themselves, invest in their education, and thereby use their skills and talents to contribute to economic growth. What about savings? Well, this is the area really where we have least knowledge. And we do know in low-income countries that this is certainly beneficial. People who are in better health save more. If they save more, and particularly where there are inter-community sort of loan systems and so on, then there's more money available for startups of businesses and small and medium enterprises and so on. We don't have that evidence in high-income countries. Very difficult to do the research, but it's plausible that people who do think that they're going to live a long retirement are going to save more. And of course, then we're dependent on the capital markets to invest that money sensibly, as opposed to gambling it in some casino on Wall Street. But that's another story altogether, about which I will be talking in Auckland on Friday. What do we get when we pull all of this together? Well, this is a study which looked at the European Community Household Panel data with a whole series of waves over a period of time from the mid-1990s through to the early part of this century, looking at older workers. And it looked at the effect of changes in what they called health stock, which was essentially the health that people had coming into the survey. So if they had a high health stock, they were healthy, they didn't have chronic diseases, they didn't have disabilities and so on, and you could compare the effect of going from really being totally healthy to having some health problems and progress down there. And then you could also look at the effect of a health shock. Again, this is the economic terminology, but it essentially relates to a sudden severe deterioration, like a heart attack or like a stroke or something like that. And then adjusting for all sorts of things, what did they find? Well, they found that if you looked at people who had, and it was just 1 unit more, or 1 unit less, I should say, of health stock, so it's difficult to quantify this, but it would be like moving from good to just okay health, that sort of level. It significantly increased what people described as retirement, but of course this reminds us that we need to look beyond people saying that they're taking early retirement to all the reasons why they exit the labour force, because it will vary between countries. They may leave for what they call early retirement. As I said, they may leave for being an invalidity benefit. They may leave for all sorts of other things. And so you see a greater effect. And again, with a health shock, anything other than the smallest of ones, and even the smallest of ones, has an impact on some form of leaving the health workforce. So we can see, wrapping all of this up, there's a major issue in terms of keeping people in the labour force, their productivity. There's a significant rationale for investing in the health of your population. And if you are a finance minister and you're asked to spend money on boosting the economy, which is, of course, what finance ministers are meant to be doing. Often finance ministers will have no qualms whatsoever about saying, we should invest in high-speed internet for everybody. Now, I know there are issues about how you can get it, when you have to sign up for it, and when you can get it, and so on, but high-speed internet, transport infrastructure, airports, railways, motorways, all that sort of thing, those are means of promoting economic growth. Investing in higher education, another way in which finance ministers are normally very happy, although that's been changing in some countries like my own and Australia recently, but generally those are the sort of things that finance ministers are happy to do, to invest in things where they think it will lead to greater economic growth. All I'm arguing is that health goes in there too. It comes out of the basket that the finance ministers put it in. They put it in the sunk costs, they put it in the money wasted, the money, it's been spent, we've done it, once you've spent it, that's it, we get nothing back in return. I'm arguing that we take that money and we put it back with education and infrastructure and high-speed internet and all the other things, because there's clear evidence that it will have a significant impact on the growth of the economy. Now, so far what I've looked at are the microeconomic effects, the effects of one person becoming healthier, albeit in large studies, but essentially looking at the impact on the individual. What about on society as a whole? And there we see that if you look over time, and this is work of economic historians, in particular Fogel and Aurora, that they looked right back to the 1780 onwards in Fogel's case, and said that about 30% of the income growth in the United Kingdom was because the population became healthier. The population was better nourished, it was able to do more, it lived longer, it invested in its education, all of the things that I've said. So a significant proportion was due to simply a healthier population, not having children with rickets who couldn't do anything, and so on and so forth. Other things were important. The Industrial Revolution was important, of course. All of the things that you might expect, but this was a very serious economist who reckoned that about a third of the benefit, the gain that had been achieved, was due to better health. And then similar findings over the last century from a range of other industrialized countries. Work that my colleague Mark Shurka who did, and Mark and I have worked quite a lot on this, much of the work that we've presented here, looked at the role of cardiovascular disease in economic growth, essentially looking at 26 high-income countries across the OECD, data from 1960 up to 2000, looking at per capita income. And just to cut a long story short, essentially what it showed was a 10% decrease in cardiovascular disease mortality rates among the working population, holding everything else equal, taking all the other measurable variables that we could into account, led to, if you have an increase in CVD mortality, you have a decrease of the per capita income growth of about 1%. So high rates of cardiovascular disease because of skilled people leaving the workforce in their 50s and 40s and 50s at their most productive time has a significant measurable impact. Now, I've already talked about pensions and pension ages. I've talked about the check solution and so on. An awful lot of this depends on when we have retirement age, because people are, of course, most productive, and the measurable productivity is when they're in paid employment. I've already stressed I'm not for 1 minute diminishing the very important contribution that older people make to the informal economy, but of course this is less easily measured by the people in the Treasury. And what we see across Europe is that we have enormous variations between the proportion, the percentage of people who are between age 55 and 64 who are still in work. So if we look right up at the top, Iceland, Sweden, Norway, Denmark, Switzerland, and so on, they have a really high proportion, maybe 70 or 80 in Iceland, about 80, 90% of the population between 55 and 64 still in work. Interestingly, those are the countries with the most developed welfare states. Those are the countries that invest most in social development. They invest most in their health systems and in health promotion and public health. In another study that we've done looking at the performance of public health policies, they're the countries that come out top. The Nordic model of the welfare state, high tax, high benefit, high redistribution. leads to higher percentage of people staying in employment, exactly the opposite of what those people who say if you have a too generous welfare state, people will just stop working. It's actually completely the opposite. So that's what we're seeing there. If we see in some of the other countries where the provision is much more sparse, then people are dropping out, and they're dropping out for all sorts of reasons. So this is a key issue that we need to look at, the fact that too many people in too many countries are dropping out of the labour force at far too early a point. If they are contributing in other ways, that's great, but they aren't always. And then that takes us to the issue of looking at the working age population. If we want to expand the working age population, we can do so by indexing, by increasing retirement age. Now, of course, we need to think about new ways of working, because nobody should pretend that you can continue to do all the things that you could do at 30 whenever you're 65 or 66, particularly if you're a surgeon or if you're doing invasive procedures or if you're doing heavy manual labour. There are lots of things we need to look at, how lifestyles change and work changes over the life course. But this is one way in which we certainly can expand the skilled workforce in many countries, and we also need to look, of course, at job creation for young people. So, what we've seen here is we have seen evidence that at the micro level, investment in health improves productivity and economic growth. At the macro level, that confirms it as well. What about the actual value that you as an individual place upon your life? And here is where we get to how do you measure those additional years? Now, there are a whole series of ways, but just one that I'll pick up very quickly: the value of a statistical life. And you can put a value on how much value do people place on lives, because there are many jobs where people are paid premiums because we know that there is a risk attached to it. Oil workers, miners, people working in hazardous jobs, people in the armed forces who get hazardous pay for parachuting or bomb disposal or something like that. There is a mechanism for working that out. That is the value that society places on a life. Now, there are lots of other ways we could go into, but I just picked that up as one of the many examples of how you can do it. And what do we see whenever we actually do the sums and find out what health has contributed in terms of this total value? The value not of what the finance ministries do, because they're interested in the GDP. Now I'm moving beyond that. I'm measuring the value that you as individuals living longer place in your life. And we can see that the improvement in life expectancy over the last 4 decades has been about a third of the growth of GDP per capita. That's an enormous contribution to the sum of human happiness. If we take GDP as a measure of well-being and happiness and the progress of nations. So the improvement in life expectancy has really been quite important. Maybe just briefly, I'll just pick up on this. What we did in this study, and it's a bit complicated slide, but maybe I'll just try and explain it, was that we tried to look at how much of the improvement in life expectancy was attributable to healthcare. And what we've done here is work that we've been doing with the concept of avoidable mortality. And of course, a lot of work in New Zealand has been done in New Zealand on avoidable mortality too. So we try and pick up those deaths that should not occur in the presence of timely and effective care. And we look at the improvements that have been achieved in that over a period of time. We place a value on those additional years of life, and then we look at how much extra was spent on the healthcare system. And what we see there is a very significant return on investment from that extra money that went into the healthcare system. In the UK, 148%, in Sweden, 274%, and so on. It varies between countries, but it's a lot. So essentially, if you look at the value that you as citizens and as voters place on the additional years of life that you're enjoying compared to your parents, then the investment has been absolutely fantastic. If you could get returns like that on your pension funds or your investment, you'd be laughing. Unfortunately, you can't. So this is a very good way of getting gains. It's just a matter of putting a monetary value on it. When we talk about investing in health, of course, there's another question we need to consider. And that is when it is appropriate for the state to intervene. Because you could say, well, it's great that you live longer, but that's a benefit to you. You're enjoying those extra years, but why should I pay for it? You should be putting that money in yourself. And of course, there are a lot of people who do take a rather different view from what I might do as a public health physician. The economists, do people want to be fat, smell like ashtrays, and die early? Let them. The state has no business with your plate. Intercontinental health nannying, again, The Economist, the Financial Times in particular. And so there is a strong view that even though there may be these economic gains, they should be private gains, they should not be public ones. And the public, the state, has no role in contributing to this. Now, of course, you could say that that's a perfectly reasonable argument, and maybe the government and the state should not have any role in protecting your health from external threats like smoking and marketing of soft drinks. And let's just continue that, because the logical extension of that is that the state should have no business in protecting any of you from, for example, terrorism, or in New Zealand, less of a threat, I admit, invasion by a nearby country. But do you have to say, well, why do we have armed forces? What is the argument for that? Surely they're protecting lives as well. The healthcare system is just an extension. It's a bit like turning Clausewitz on its head about war and politics being an extension of each other. So you can then start saying, well, there is an argument that if the state has a role in protecting the health of its population, which it clearly has, because otherwise it wouldn't spend money in defense, then there is a powerful argument for doing it in other ways too. What is the point of having safe borders if everybody is dying at the age of 20 inside your borders? But of course, there are a number of reasons why we do, and why the state does invest. And that's because, of course, we've got market failures. This goes back to Ken Arrow in 1963. There's a whole series of reasons why markets do not work in healthcare. And we're always very grateful to the United States for providing us with such a wonderful natural experiment of how you can introduce market mechanisms and spend 17% of GDP and get some of the worst health outcomes in the Western world. Unfortunately, my country and your Western Island are engaged in a similar experiment at the minute, introducing many more market mechanisms, and you should be grateful to us for having that experiment and learn from it. But the thing is to learn from it and learn the right lessons, just like we learned lessons from you during the 80s and 90s with some of the interesting experiments that you had with markets and healthcare, for which we are grateful. And the key issue here, of course, is the external costs, that there is an argument on the fact that people are paying for things, but actually there are a whole series of costs that come with them that are not factored into the cost. So if we look, for example, at the cost of smoking, and we work it out in terms of the total cost over a lifetime, in terms of health effects and loss of earnings and loss of all sorts of other things, in fact, as in addition to the cost of paying for the pack of cigarettes, they will be, by buying a packet of cigarettes and smoking it, they will effectively be losing about $32 for every pack they smoke. There will be other costs that come with that, cost to their family of loss of income, of illness, and all sorts of things, increased cleaning bills and so on and so forth that go with that. But there's also an external cost to society. So there is a strong economic argument for factoring in these externalities. Now, some years ago in the United Kingdom, the Treasury, not interestingly enough the Department of Health, who were actually quite miffed that somebody else was doing this, but this was under Gordon Brown, they looked at healthcare and said, what is the future? What are the alternatives? Where should we be going? And this was produced by Derek Wanless, who was a banker. Questions, what's the best way to pay for healthcare? To cut a long story short, general taxation. Absolutely general taxation. It's the simplest way of paying for healthcare. Everything else is far too complicated. Social insurance models may have worked in the 19th century when you had the traditional family of a male breadwinner and a non-working wife and a few dependents. Doesn't work that way anymore. Even then, the state had to come in and do all sorts of other things. Co-payments, sorry folks, not a good idea, and it's even less a good idea of keeping them at all. If you're going to take them out for the over 65s, I would say take them out for everybody, because all you're going to do is stoke up intergenerational envy. And for those of you who are approaching 65, that's the best way to get younger people to hate you. So think about that when you're talking to your politicians as well. And what did Wanless conclude about the best way to control future expenditure? Because there was a concern, is the healthcare system affordable? Is it sustainable in the long term? You may have heard questions like this asked by other people. And they concluded that actually it was perfectly feasible. If you had a fully engaged scenario, preventing illness from happening in the first place, treating it early, not being like the United States, where people with diabetes who cannot get medical cover then present late, so you have massively higher rates of amputation, 3-4 4 to 5 times higher than in the UK of lower limb amputation, who come with cellulitis, who come with all sorts of problems, who have blindness and renal failure and so on. Intervene early, treat people properly, manage hypertension properly, and prevent illness, and you will save a significant amount of cost. So what I've tried to do in that brief overview is to say, whatever way you look at it, direct cost to the healthcare system, okay, it will cost a bit more, but you're going to get a lot back for you as taxpayers. You'll live longer. The benefit in terms of investing in health are as good or better as investing in all the other infrastructures, be they communications networks, broadband, internet, everything that you can think of. In terms of productivity and keeping people in the labour force, you may have to do something with retirement age. And the value of a life, the investment, your investment in your own health, you will get a very significant return on investment. Very briefly, to go back to this point about this three-way relationship, the relationship between health systems, health and wealth. I've talked about the contribution of health to wealth. What about the contribution of health care to economic growth? Well, there are different ways of spending money. One of the key things here is to get the biggest bang for your buck. And particularly in a country like New Zealand, how do you make sure that you get as much benefit from what you spend as you can? And here the answer is something that's been picked up in Germany, it's been picked up in a number of other countries. Take an example of building a new hospital. One thing you might do is you might have one big tender. And you say, we want somebody to come along and give us a new hospital. Just everything, design, build, operate, DBO model. And what you will then find is that there's a handful of global companies that can come in and do it. And in fact, they can do it easily because they've already got the documents. You've probably copied the tender documents from somebody else, just like one does with union rule books, for example. You find somebody that's done it before and you take it, and they've already got the answers. They've got it on their shelf. They never throw anything out either. So they just produce it and they delete Australia, delete Western Australia if it's Serco, insert New Zealand. It's dead easy with a word processor, and it's all there. And meanwhile, your own indigenous New Zealand companies are saying, my God, how do I start with all of this? We haven't built a hospital before. What do we do? How do we get the bits? What does the document look like? Where do we go? So you're going to benefit them. These are going to be large corporations that will be based in the Virgin Islands or somewhere like that. They'll work it out so they pay no tax in New Zealand. They'll bring people in elsewhere to work. There'll be no money going back in the economy. So you can do things by breaking it up into smaller bits, getting a lot more work for you, but that will boost the New Zealand economy. And that's what's been happening when we've been looking at European Union structural funds, because what we're finding is you can break up the contracts, you can support the local economy, and more than that, in the same way that universities in Europe, in many parts of Europe, the newer universities have been located like Maastricht in the declining coal mining areas, the places where there was no employment, the mines shut, the foundries shut, so somebody had the wisdom to put a university there, and you actually kept the place going. Healthcare facilities investment can actually keep people in the same way that if you close a small remote hospital, you will never attract inward investment. You will not get the foreign direct investment going in there. So health systems contribute to health, to wealth in that way. But the other thing that they do, and this is work that we've done looking at the role of the impact of the financial crisis. You've seen that the French government collapsed yesterday, and one of the issues has been the issue of austerity, about which I'll be talking a lot more in Auckland on Friday. And the argument that if you spent money on healthcare, you've lost it. But of course, or if you spend money, in fact, the traditional view was that if governments spent money, it's wasted. The argument that governments are hopeless at knowing where to invest, forgetting the fact that it was actually the internet developed by the Department of Defense in the US, so it was developed by the US government, forgetting the fact that many of the advances in avionics and aviation were developed with US government funding and so on and so forth. So actually much of what is around us, Teflon by NASA, funded by the government and so on, leaving aside and ignoring all of that, there has been this view that if government spent money, then it's lost, it's wasted, and what was called the fiscal multiplier, the growth of GDP that resulted from that dollar, was traditionally felt to be about 60 cents or 70 cents. Olivier Blanchard, chief economist at the OECD, looked at the figures again and looked at it now in the current period and said, actually, it's not about 60 cents, it's about $1.60. Governments spent money effectively. If they invest cleverly, they will get more economic growth than the money they spent. Now, what we did was then to say, well, that's fine for the government as a whole. What about investing in different sectors? And what we found was that if you looked at the investment by sector, it wasn't 1.6, and this is on you can see here the return on investment in health actually was about 3.5, 4. The investment in culture and recreation and education was even higher. The one area where investing did not do so well was in defence. And that's actually entirely logical, because in the United Kingdom we've been spending a great deal of our defence budget, but we've been spending it boosting the economy, not of the United Kingdom, but the economy of Afghanistan and the economy of Iraq. We have had a massive Keynesian fiscal stimulus to the Afghan economy, which is a good thing. I'm delighted that it's happening. It would be just unfortunate so much of it has gone into poppy growing, but that's another point. And so therefore, it's not surprising that this is the case. And what we're doing by investing in health and education is that we're putting money not into the multi-millionaires who will take it to tax havens and save it, but we're putting it into the pockets of low-paid workers. And those low-paid workers are not saving it because they can't afford to save it. They're spending it, and they're spending it in local shops, and those local shops are spending it on local accountants and local lawyers and local builders and so on. And all of that is making the economy go round. So it's entirely intuitive that spending money on things that go into the pockets of low-paid people will actually boost the economy. Now, this is not rocket science. This was known in the 1930s. This has been known for a very long time. It's just that under political influence in the 1980s, it's been forgotten about, deliberately forgotten about by Milton Friedman and the Chicago School of Economics and others that you're very familiar with. But what we've seen is we're simply relearning the lessons of history. FDR would be returning in his grave to think of the mistakes that we have made given what he showed us in the 1930s. So what I'm trying to argue in this, and what we argue in the book and in a number of other places, is that the challenge that we face is to create a virtuous cycle, where we look on investing in health as a contributor to economic growth. And that economic growth then can be fed back to help people to make healthier choices, lead healthier lifestyles. It will actually reduce the future expenditure on healthcare because people won't need healthcare to such a great degree. But the money that we do spend in healthcare, that can then be fed back, and that can be used in clever ways that boost our economy as opposed to the economy of the Virgin Islands or somewhere like that. All of this is possible. It just requires vision. It requires interconnected thinking. And I think for you as salaried medical specialists, I would say, you know, I'm a physician too. I trained in medicine, I trained in internal medicine, public health. You know, this isn't my area. I'm not an economist. But by engaging in these debates, one is able to put forward these more nuanced discussions. You already do it. You've got a lot of expertise. The report that you just brought out I thought was great here, really good. I think the ASMS has really been at the forefront of some of this thinking. But I think you can make a real contribution by engaging in these arguments, having the evidence, and putting them forward forcefully. And with that, thank you very much indeed.